Good morning, everyone. Happy Saturday. It's my honor to be here, and thank you for being here today. So what I will do is I would like to talk to you about the use and integration of the conversation map tools here in U.S. as well as internationally. So my focus is going to be about showcasing, even though the world is very diversifying, however, the use and integration of the map tools is very universal everywhere. So that's what my hope for today is. As Joellen mentioned, I'm a lead facilitator for the conversation map tools. What that means is that I work with the local healthcare professionals on the use of the map tools within their healthcare system. So therefore, today I'm going to represent the stories that I hear from those educators, and many of you are here today. And then also, I'm really here to celebrate diabetes education because the MAP tools are there to deliver diabetes self-management education and support. So it's really about showcasing what MAP as a tool and how it delivers diabetes education everywhere. So my disclaimer is that I work for Healthy Interactions. And Healthy Interactions is an educational company, and our primary mission and goal is to help people with chronic conditions to change behaviors or modify their behaviors so they will become healthier. As Marty said, healthier self-manager of their condition. So with behaviors, it is a good and a bad thing because with unhealthy behaviors, things get worse with disease management versus healthy behaviors, things get better. So our mission is really help people with chronic conditions to improve their health behaviors and become healthier individuals. So I've got 2 learning objectives for today, and I'll be speaking for about 35 minutes or so. And then we will have time for questions as well. So is to exemplify the use of the conversation map tools here in U.S. and outside U.S., as well as share with you some of the program outcomes and deliverables. So it all started in Canada in 2006, where this initiative was more of a local scope in collaboration with Canadian Diabetes Association. And then later in 2007, what Marty was mentioning, we launched this program in U.S. with our wonderful collaboration with American Diabetes Association. And with American Diabetes Association, we were able to reach about 30,000 healthcare professionals. 30,000, 29,000 as of January. That's a lot of healthcare professionals. Here in U.S., we have, I believe, about 16,000 certified diabetes educators. So half of the people that are using the MAP tools are not certified diabetes educators, but more so of the clinicians, nurses, dietitians, physicians, pharmacists that are providing diabetes education. So this, as I speak, you'll be able to also see that the MAP tools do way more than providing education. They're also a very good tool to grow skills in diabetes self-management education, because as clinicians, we grow our skills by providing more diabetes education. So the more we see patients, the more we interact with patients, the more we teach patients, the more we learn. And that's how we become more skillful in our role as a diabetes educators. Then this wonderful program came to UK in a local Diabetes UK partnership, and at this time we have reached over 3,000 healthcare professionals who have been trained on the use of the MAP tools. When I say train, that means that they have the actual map, all of the MAP tools, and they're able to use them. And the training happens by local professionals who speak the language. So I'm not the one going everywhere and training everybody, but we have expert trainers or lead facilitators who are qualified to really mentor and then support the local use and integration of the MAP tools. And in 2008, it became global. And global, that's a lot of countries because it's over 120 countries. So this approach, even though it's in the different countries and over 38 languages, regardless of that, people around the world in over 120 countries are experiencing the same patient-centered, learner-centered integration that is engaging, empowering, and really focusing on the individual needs, even though it's a group setup. So in a group of 3 to 10 people, even though it's a group education, each patient is getting a very individualized care. So this is a short video to show you a typical MAP session. The conversation map, which is in front of you, is designed to engage a group of people in a conversation that is both informative and meaningful, so then you can learn from each other. So Karim, what are your concerns about living with diabetes?
Well, as a busy professional, I always find myself in the airport or traveling and just having to make, the right food choices, and it's just been very difficult. So I like to find out, what are the better choices that I can make.
How about you, Nelson?
My doctor talked about strict diet, exercise, medication. I just hate all those things. Is there anything that's more natural, holistic, so to speak, that you do that could help?
I don't think I can do this. It's way too much. I wish you guys all the luck.
You're sounding like you're very fearful, angry that you have it. Why me?
You guys angry?
Oh, sure, you're angry, and you're very scared. I can tell just by looking at your face. I think we all probably felt the same way when we were first diagnosed.
Oh, sure, it's natural. Mm-hmm.
So I don't know what to say to encourage you, except that we've been there, and I think we all have a little more hope now that we can control it.
It is manageable.
And Estella, diabetes is so difficult. Sometimes when you do it as a family and you all can support each other, you'll be more successful in the end.
That'd be good.
It's like going on a diet. One person in the house is on a diet, everybody else is eating everything. Okay, one person feels left out. This way, if you're all doing it together, nobody knows the difference.
Support groups are great.
Right.
What happens to you, Nelson, when you eat too many carbohydrates?
I take a nap.
Well, those are the bad carbs.
Right away, those are the bad ones.
But is there something that tells us what's a bad carb and what's a good carb?
What's a good carb?
Gives you energy.
Whole grain.
Whole grains. Wheats.
What's not
beans.
good carb?
Bread, white bread.
White bread.
Flour.
Potatoes.
A lot of pasta.
Refined.
Pasta.
Yes.
So you can see that I really wasn't teaching. They were teaching themselves. So as a MAP user, it's a complete pleasure because I'm just sitting there and relaxing, having a nice time while people are enjoying themselves. So then later today, Chris is going to get you through your own MAP experience so you can experience it from a perspective of a learner, not necessarily as a person with diabetes, but as a healthcare professional who you are, but experience it so you can experience the engagement to better illustrate or demonstrate how this process goes. So you can see that it all starts with before people people with diabetes eventually learn, they need to believe that they need to know before they can learn and wanting to know. And then once they know, they'll be able to act on their behaviors, and then as a result, they've improved their daily tasks or daily behaviors and become better self-managers of their diabetes. And that's what we do. We deliver those personal health engagements that create behavior change. So why does it matter that people need to be engaged in their self-care management? So we know that engaged people are able to better perform in their self-care behaviors. They use self-management services more often. They also report high medication adherence, and they're also more likely than doctors to initiate discussions about their symptoms that are related to diabetes and medication use, and they're more involved in the decision-making, as well as 10 times more likely to have a high patient satisfaction scores, and overall they just have a better functional status because they're engaged in their care, and therefore they're more they own their condition, so they're more likely to act on those things that they need to do to feel better. So what I'm going to do next for the next few minutes, I would like to give you examples of how the program or the MAP tools are used in different countries. So I have divided this presentation into 3 categories because the MAP tools do a little bit more than educate people with diabetes. Well, they also advocate for better access for diabetes education because, as I have mentioned, over 80,000 healthcare professionals throughout the world have been trained on the use of a conversation map tools. So those healthcare professionals are using the map tools in different places. They're using them in Africa, they're using them in Canada, and Poland, all of those places. So the people with diabetes are getting very standardized education no matter where they are. But they also advance our profession of diabetes education. And advancement happens because the healthcare professionals are able to have a curriculum that is evidence-based and is providing the best in patient education. So in UK, the reason that I have selected UK is because it's a good example of where these map tools are fitting into the existing healthcare system. And in UK, the diabetes education system is very well developed and established. They have our equivalent to certified diabetes educators, clinicians who are very skilled and well prepared to provide high standards in diabetes education. So in UK, we have over 3,000 healthcare professionals trained on the use of a conversation map tools. And what we have there is kind of like, it's called NICE Criteria Toolkit, which is very unique because the centers who are submitting for the reimbursement, they're able to use the map tool to really fit into the reimbursement system. So like kind of in here, we have AD recognized programs or AD recognized programs. In UK, the programs have to be supported by the national sick funds, and then but there are specific regulations that they have to audit, they have to have an evidence-based intervention, has to be provided by skilled clinicians, and so on. So these, the conversation map tools really fit into that fairly complex and sophisticated system. So we have surveyed the healthcare professionals who have been trained there on the use of a conversation map tools, and this is some of the feedback that we have been provided from them. And this is after they attend training to know how to use the map. So, and after they attend a training to use the map, we often call them facilitators because they're able to facilitate the conversation map tools. So, upon of the completion, over 90% of those are map users or ready to use the map tools with people with diabetes. But this is interesting because it kind of asks the diabetes educators in UK what about the tools makes it special. So majority of them really value the fact that it stimulates discussion and peer interaction. It's kind of interesting because you would assume that, it's good because people learn or something like that. But a majority of the map users there actually like the fact that people talk, that people engage. And then it makes the group facilitating more interactive and engaging, increases concordance, which is the British word for better relationship building with patient and healthcare professionals, and then adherence and so on. So it just seems that the diabetes educators in UK really value what the map tools are meant to deliver. So it's a good match. And then this is also a good one because you can see that we ask if they're using the map as a main curriculum to provide diabetes education versus a supplement, because these tools can be used either as a standalone curriculum when structured diabetes education is being provided. Like the information that Marty was saying that there is 4 map tools here in U.S., and the reason for that is because we have 9 group education hours to provide diabetes self-management education to be reimbursable. So in outside UA, the term is called structured diabetes education. So structured means that it's provided by qualified professional and is reimbursable and so on. So in UK, you can see that people are using it both as a structured diabetes education as well as supplement to the existing curriculums or other ways of providing diabetes education. So this is how do they audit? Audit means evaluate the effectiveness. So session evaluation only for majority. Some people don't audit. Some people do clinical care markers. And then you can see that majority of the people look for more of a satisfaction from a session. Ask the patient, did you like this way of learning and so on. I always say that the best way to evaluate if the map tools are effective is if people keep on coming back to the sessions, and then we're able to invite them back when they want to be coming back, that means that the session was successful, because that means that they're engaged and they're activated enough to come back. And diabetes education is really dose dependent. So the more we do it, the more we interact with people with diabetes, the better outcomes are happening. Israel. So Israel is unique, and I put them under advancement, is because it really advances the profession of diabetes educators there. So there's, I think at this moment, over like 500 advanced level nurses who have been using the conversation map tools within their sick fund. So it's fully reimbursable within the different healthcare system, and it's very unique because all of the people with diabetes within that healthcare system are able to go to the conversation map tools as a whole curriculum. So there's 4 map tools in addition to additional ones, but at least 4 minimal. And it's what they do is they also take the map, like a super map users, healthcare professionals who have been using a lot of it, and they mentor others. And right now their plan is to really take it to the primary care, where people with diabetes come and then get a lot of interactions with the primary care with physicians. The plan is to train the local nurses who are not advanced level diabetes educators in using the map to help them to reach out to more patients. Brazil. I have Brazil because it's Latin America and it's fun. So Brazil is cool because they use a very multidisciplinary approach to this. So they have a psychologist involved in diabetes education. They have a nurse. They have a dietitian and a physician. It's just so nice to see that those different multidisciplinary teams, but they're providing the same service. So it's really uniting them in that way. So we're using it in both private and local hospitals. And also this program outside U.S. is in our partnership with International Diabetes Federation. So it's developed in collaboration with IDF. And IDF has wonderful education center of educations. I think it's over 20 of them right now, or about 20 internationally. So Brazil has one of those IDF education centers, and they're using it. And they're really creating the best practice and exemplified to others that diabetes education is really a multidisciplinary approach, and it's dose dependent, and we want to use evidence-based intervention and so on. So Brazil is doing a wonderful job. Turkey. The reason that Turkey is unique is because they take diabetes education when people with diabetes come. So a lot of times they have sessions for people with diabetes in the mall. And what's very unique, because everybody in the world has the same problem or the same challenge. People do not come back for diabetes education, or don't want to come back. Like, to retain the patients, once you activate the patients, to keep them coming back, that's a challenge. So they are very creative, actually. They have those graduation ceremonies. So in those malls, like, people are more likely to come in because upon of the completion of a program, they get a picture taken with their certificate. So they make it more fun, not like hospital kind of intervention. But they do have a wonderful team. Over 70% of diabetes nurse educators in Turkey have been trained on the use of the conversation map tool. So it's a big outreach there. Japan. Japan is here to kind of represent the Asia component of this. So in Japan, the reason that I put it as an advancement is because we launched in Japan in 2008, and over 2,000 healthcare professionals have been exposed to the conversation map tools. But Japan was also looking into how many of those 2,000 healthcare professionals are using the tools. So they strategized with the local association, which is called JEDEC, which is Japan Association of Diabetes Educators and Care, which is a healthcare professional association. Again, here in the U.S. we have AADE, and there they have JEDEC. So they launched a national campaign to really identify the best diabetes educators, and put those tools in the hands of those good diabetes educators, so those diabetes educators are really driving the best practice and setting standards for diabetes education. So they have done a wonderful job with that, and then the program is very successful in Japan. Africa. So Africa, notice that I have those little flags. Africa has over 20 different countries that are part of this initiative. And in Africa, the conversation map tools are really closely managed and deployed with our partnership with International Diabetes Federation. But we have a program coordinator. Her name is Ati, and she's working very closely with the local healthcare professionals to mentor them, to help them to integrate the conversation map tools. Because in Africa, it's not just access to diabetes education, but also helping healthcare professionals like physicians, pharmacists, to really develop skill sets to provide diabetes education. So more attention is given because their needs are different than in different countries. And their way that they evaluate their progress is they looked at the knowledge scores, are people learning more, but also looked into their clinical care outcomes, and they have shown improvement. But it's very nice with this African partnership because in Africa, diabetes education just doesn't exist. So our partnership with IDF is really those healthcare professionals are expert trainers. They end up going to health ministries and then convincing health ministries to be able to appoint, let's say, a nurse, educator, or a physician or a pharmacist or whoever is there to advocate for diabetes education. So it's amazing to see that in Africa that strong advocacy where we almost build a profession of diabetes education is happening, and that's all in collaboration with International Diabetes Federation, that that advocate for people with diabetes. So India. The reason that India is unique is because India takes it to, and there's a lot of good news in like employee health. Because the healthcare system in India is like typically self-pay, and then the public pay is very difficult to provide diabetes education because a physician might see 200 patients in a day, and the profession of nurse is not very advanced level, so nurses are more like a technicians. They will not be in a position to educate a person with diabetes. So what's interesting is they're building that profession by creating counselors, and those counselors are the ones that are becoming diabetes educators, and they're doing it like in employee health. Like, for example, like in a big, let's say, organization, they would have people who are employed, then they, as a benefit, they're able to, people with diabetes can attend diabetes education. So what's unique also is that those counselors, they're all healthcare professionals, but more like public health professionals. Their knowledge about diabetes has really improved. Like if you look at it for the average pre-test score, it was 3 out of 10. Those are the people that already were working and educating people with diabetes. Years after, we started to use the map. With one map session, it went up to 8 out of 10. So those educators who previously were already teaching people with diabetes, their knowledge level about diabetes or confidence was pretty low. So it's nice to kind of see that not only patients or people with diabetes are learning, but also the educators are also learning. So outcomes and deliverables. I have a few information to kind of share with you how do people measure their success? Because a different country, different healthcare system, different healthcare professionals, what's meaningful to them might be not meaningful to us. So as a program, we really don't dictate how people measure their success. We want people to measure what's valuable to them and what will increase the satisfaction within their healthcare system. So the program is really designed anywhere, in U.S. or Africa or anywhere, to be outcome-driven, to produce better improvement in patient engagement. But it can be adapted from the big places as a supplement to the existing system to fill the gap. Wherever people with diabetes come, we really want the map tools to be there and be available so the healthcare professionals can have a simple way to really provide high standards of diabetes education. Here in U.S., and Julia is going to talk a little bit more about that, the curriculum is, the map tools, as Marty was showing, fit our existing ADA clinical practice standards. So it's it's group education, it's patient-centered, but it's not just, fun and education. It's really a curriculum. So it does have all of the content area that people with diabetes need to know in order to function well within their medical condition. So Australia, I just took an example of the outcomes for diabetes self-management education. Now we have a new updated position paper or guidelines. It was just published at this conference, so we know the diabetes self-management education and an outcome it produces. The time when I was doing that, I took as an example for DSME. We know that DSME works and it does reduce hemoglobin A1C. I have this out for you because the conversation map tools are there to really drive and deliver diabetes self-management education and support. So it is compatible. Whatever DSME is meant to deliver, the map is there to drive it. But there's other components. And we know that also DSME saves money in Australia. It is for every $173 Australian spent, there is over 2,000 Australian dollars saved. So DSME is really effective, and it does produce outcomes. Just has to be delivered and provided. And if it is delivered and provided, it works as good as the best medication. It is like a pill. So I did divide my outcomes and deliverables into several categories to simplify it: empowerment, self-care, clinical, and cost implications. So we can kind of see different examples of different outcomes and how are they being measured. So Pakistan. Pakistan is really looking into empowerment and engagement. So it's interesting because in Pakistan, when we started working with Pakistan, it was always, well, our patients really want information. We're not going to, the doctor is so important, the clinician is so important, they will never be able to interact and talk to us. And they want doctor to prescribe the right medication, they want healthcare professional to tell the people exactly what to do. And it ended up to be not the case, because once I started to use the conversation map tools, people started to talk, were engaged. But what's very unique about this specific outcomes is that patients at the beginning of a session believe that the doctor was responsible for their diabetes self-care management. Upon of the completion of the map sessions, they took the ownership of their condition. I think it's wonderful to have the people, to give the people the power of owning their own condition, their own life. And that's the only way to improve clinical care outcomes, by allowing people with diabetes to do what they know is right. So we're not telling them what to do and how to do. They know what to do. They know about diabetes. We're there to really support them in their journey, to really help them and partner with them to do better with their diabetes. Taiwan. The reason that I have Taiwan is because that the very similar kind of situation. This is published here, was one of the posters at ADA. So they found that people are more adherent, and then researchers concluded that 3 months after intervention, using the MAP tools was more effective than the usual diabetes education. And this happens because sometimes people are just so used to using a PowerPoint, and then it's so much easier, they would assume, to use the PowerPoint. And the best way to kind of see if you're using whatever you're using, just compare map to a PowerPoint or the other way, and see what is the patient retention, what the patients are saying. So they did that, and they found out that within 3 months, the conversation map tools produce a better outcomes with their usual PowerPoint intervention that they do. In U.S., and this is just published, it was literally in Diabetes Spectrum this month. And the reason that I have this, and even though it's a small study, over 30 people, veterans, and it was conversation map tools, only one tool was used, the journey, continuing the journey, medication tool. And the pharmacists were using it, and they looked into if it met the needs of educating people about medication. So this is a nice self-management kind of reflectory. Did the map tool deliver on what they wanted to teach the patient, which is good because we still have to teach. And we still want people to learn something from the sessions. So we're able to kind of look into what people learn and what people didn't learn, and as a result of that, kind of adjust to it. And Italy, I have Italy here because this is an example of the clinical care outcomes improvement. In Italy, they already have a very patient-centered, very therapeutic, healing diabetes education systems. So their physicians, endocrinologists, they have more time to talk to people with diabetes. They like conversation. They like fun. So it's an easy sell in terms of like, oh, we have people to talk. We have this map that is all about kids. So it's kids and the family members with diabetes. So early when they do it, it's just it's meant for have like 5 to 10 kids in a session, but they can only invite 2 kids because with those 2 kids, the whole family comes, so they have 20 or 30 people in the room. So they do like the discussion. They're very patient-centered, but family-centered. So they just looked at if the MAP2 improves clinical care outcomes, and it did. It lowered the fasting glycemia, hemoglobin A1C, and BMI. But it was an outcome that was meaningful to them. I got Israel again, but this is just to kind of show you. Sometimes people ask us, how do we make our administrators in our hospital to give us time so the nurse will be able to see people with diabetes? Because the nurse has to do so many different things. The nurse does not have time to see people with diabetes. We give person a handout and then education, and they leave. And in Israel, they really, in order to allow the sick fund to reimburse for that 2 or 3 positions of nurse educators in that healthcare system, that their full-time job is to go around to the patients' rooms or provide group education, they literally looked at the outcomes. They measure for 6 months, I believe, or 6 months or so, and then see if the hemoglobin A1C and fasting blood glucose improved as a result of DSME, and it did. So they're able to justify it, and they have several full-time nurses now providing diabetes education. In UK, I have just an example because sometimes we say that it's an indirect and direct cost implication. So in UK, there's a very sophisticated diabetes education system. It's called DSME. It's the same methodology as ours. It's the same thing because group education, patient-centered. So, however, it's fairly expensive to run. So one of the educators wanted to see if the conversation MAP2s are provided the same interaction that DSME does, and it showed that it actually provided the same interaction. The difference is that the MAP2s are cheaper because, they're always free of charge to healthcare professionals. So in addition to additional things, they decided to incorporate it into different places. This is just an example of another indirect cause. It's just they found that there's less hypoglycemia with the use of the diabetes education. Frequent hypoglycemia is expensive. So this has an indication is we educate people about hypoglycemia management and prevention, being more proactive. It will eventually cost less money in Taiwan. So I'm almost done with my presentation, but we do have a review of all of the studies. What's nice about these studies is that they're not health interaction studies. They're just local studies that healthcare professionals have done to measure what's meaningful to them. So that is available. So you can we have a summary of it, so you can go on our website and it's there if you would like to kind of learn a little bit more about that. And that concludes my talk. Thank you for your attention. I think I did it in less than 40 minutes.
You did good.
I talk fast. Thank you. Thank you.
Does anyone have any questions for Barbara? Do we have some?
The microphone. There's a man over there. See him?
Yeah, thank you very much for your presentation. I work in a developing country. The issue of diabetes self-management education, many research projects, just like the ones you outlined, shows that it's beneficial. We have done studies in Africa and Caribbean looking at the perceptions of nurses and dietitians towards diabetes self-management. And the result is obvious. It's presented downstairs at the poster section. The result hinges on the economic limitations and the infrastructure and training. I want to know your view about the perceptions of healthcare providers in developed countries, Western Europe and North America. What are the perceptions of healthcare providers in self-management education, as that of developing countries are, as you must know, hinged on economic limitations? Thank you.
It's brilliant, and thank you for doing what you're doing. IDF, International Diabetes Federation, there is a publication that it's called Diabetes Atlas. It looks at the different perceptions and the impact of what diabetes as a condition does and a perception of like what the trends are. So there's a good resources to kind of reference that. But my personal experience with working with healthcare professionals from Africa is that the leaders yourself who believe in diabetes education, it's not just to provide the diabetes education, but there's also a huge sense of advocacy to convince others, the ministries of health and so on. It's just it's in infancy. But what's good about Africa is maybe there's less of those healthcare professionals who are providing diabetes education and advocating for it, but they're exceptional. Like sometimes I often like when I'm there and I hear their speeches, I'm like, I'm motivated. I want to be in Africa, provide education, because we really have to sell it. You know what I mean? So it's growing, and then with the initiative with IDF, it is really providing the stronger education. There's a curriculum that IDF has that actually teaches healthcare professional skill sets and not just knowledge, what they need to educate people about, but also skills necessary to have that therapeutic healing environment. So it's happening. Sometimes I often think that some places in Africa have better education than we have in some of the places in Chicago that I come from. So it's getting there. Any other good questions?
I have one. Mm-hmm. Can the maps be used by peer educators?
At this time, the conversation map tools are meant to be used by healthcare professionals because they do need to know diabetes education and a clinical content to share that. So they do have to have that capacity. So at this time, it has to be used by healthcare professionals. I think it's one more. Please bring your microphone.
My question is, have we tried these conversation tools in a, web or internet, so someone who is remote?
Yes. So in certain countries, like for example in UK, here in US as well, people can interact remotely as well with that. So it's a virtual conversation map. So it's available, yes. So thank you so much for your attention. Thank you very much.